They were showing some of the pictures of these patients, and my mind was blown on the spot. You had patients with horrendous disease, large volume disease. They gave them this therapy, and it was like it melted away. And I saw that and said, you know what? We're in an age now where we're starting to see new PET tracers come out.
Welcome to the show. We're here because we're curious about medical imaging or have a hunger to learn more. What can we learn from each other, and how should we prepare to tackle the challenges ahead? I'm Chris St. John, and join me today as we rethink imaging, a podcast by Imalogics. Today, I am joined by Dr. James Cassuto, who is the Director of Nuclear Medicine at Overlook Medical Center and System Associate Medical Director of Nuclear Medicine at the Atlantic Medical Group. James has built one of the region's leading Theranostics programs using molecular imaging not just to diagnose, but also treat cancers. He's been recognized by Radiology Business as a 40 under 40 honoree and by the American Cancer Society for his work bringing advanced cancer care to patients close to home. James, welcome to the show. I am so happy to have you today.
Well, thank you. Happy to be here and appreciate the opportunity to speak with you guys.
Yeah, of course. Which, funny enough, I don't remember if I told you this when we spoke originally, but I was actually born in Summit Overlook Hospital.
All right.
Yeah. So, silly small world thing. But, I came from the very place where you are building this program. So let's get into it. Can you lay a little bit of a foundation for me about Theranostics beyond its status as a portmanteau, a hybrid word, and what is going on with it right now?
Sure. Yeah. So first, great characterization of the portmanteau. I had to look that up myself when I was preparing for it. That's a fabulous word, and it certainly I think encompasses what this is. So it's the idea that we can diagnose conditions and we can treat conditions with essentially molecular probes. I'm on the radiology side, the nuclear medicine side. So for me, this is nuclear theranostics. But in general, if I can show that certain cancers are expressing cell receptors on their surface or certain proteins associated with them specifically, and then we can guide therapy specifically to those receptors. That's what Theranostics is in a nutshell. If I can show that breast cancer patients have estrogen receptors at the tumor level, then we can treat with anti-estrogen type medications. From the nuclear medicine side of things, it gets a bit more interesting in my opinion, because we can take a molecular probe targeting those specific attributes of the cancer cell, whether it's a protein on the surface, whether it's something in the tumor microenvironment. And if I can show on imaging that there's enough density of those markers and I can get enough of this small molecule to those areas, I can make them radioactive from a therapeutic standpoint. So instead of doing something like a PET scan, which is using radiation for radioactivity for imaging, we can make those same molecules radioactive in a different way to emit beta emitters, alpha emitters, and deposit massive amounts of radiation therapy only to those types of cells. So this really lets us target only cancer cells, give the surrounding tissue alone, and we wind up getting great outcomes without the systemic side effects we're typically associating with things like chemotherapy.
So there's the diagnostics and the therapeutic side of that portmanteau. For our listeners, portmanteau, two words coming together. So you are using your scans to find these cells and mark them in the imaging. And what is I keep reading and hearing the term marking the cells. What is actually happening when they're marked?
So we're, I guess if you think of it like a key with a keychain, we got a whole bunch of doors that these could potentially go to. That key will only fit into one door. I'm looking for the key, the door that's the cancer cells. If I find a molecule of the key that's going to go there, I can switch what the keychain is. I can make the keychain a PET tracer like F18 that I can see on imaging. But I can leave the key alone. That's the marking the cell part. And then we can exchange that keychain for something else that's radioactive, like a beta emitter, use it for cell destruction and death. And that's what we use to treat the lesions. So essentially we're trying to And every cancer winds up being a bit different. So just because we say, well, this is a prostate cancer, it should have the prostate cancer marker. Some cells do, some cells don't. Even in the same patient, some tumors do and some tumors don't. So our job really is to figure out, which patients have the certain type of tumor that is amenable to being kind of tagged or labeled with these cancer-specific agents, because those are the ones we could then use for treatment.
Gotcha. And what are the cancer specific agents? What are those?
So there's a company called Novartis. They make something called Pluvicto that goes to prostate cancer. They make a drug called Lutathera that goes to neuroendocrine tumors, specifically the somatostatin receptors. There's a drug by Bayer called Xofigo that goes to prostate cancer bone metastasis. And then there's a drug, I-131, that's radioactive iodine. It's been around since the 40s, really. But those are kind of our theranostic type pairs. Xofigo is a little different. It goes to sites of bone turnover around metastasis. So instead of finding a cellular marker specific for that for imaging, we're using a bone marker for bone turnover. But the idea is the same. If we can prove with imaging that the mechanism for taking up these therapies exists, then I can send the therapies in.
Okay. I think I got it. What's going on? So I'd like to backtrack a little bit now that I have like my foundation laid and ask you about your relationship to Theranostics. I believe you once said, while still experimental, you knew that this was about, while still experimental, you knew this was what you had to be involved with, what is now coined nuclear theranostics. Can you tell me a bit about the lecture where you first heard about using these tagged molecules, and the effect that it had on you?
Sure. So I was I went to residency for radiology. I was interested in doing interventional radiology. These are procedures. And then there was an early on in that training lecture by one of our nuclear medicine physicians about an older drug called Zevalin, which was used for lymphoma. But the idea then was that you could target these lymphoma cells with a Y90 version of these theranostic pairs. And I had never heard of that before, never seen it before. By the time I was in training, that therapy had kind of fallen out of favor a bit. But they were showing some of the pictures of these patients, and my mind was blown on the spot. You had patients with horrendous disease, large volume disease. They gave them this therapy, and it was like it melted away. And I saw that, said, you know what, we're in an age now where we're starting to see new PET tracers come out, specifically for disease, not necessarily for therapy at the time. But I kept thinking, man, all you have to do is make them the other version of radioactivity, and then you're going to wind up changing cancer care. And that reminded me a bit about what I had seen even before that in research, not realizing at the time, but we were making these kind of protein-labeled sugar molecules that we could detect on imaging. Someone was using it to localize the sites of MS to try to deliver therapy. This was over at in Oxford, where I had done some research. Our lab was using it with inflammatory markers. Now maybe 12 years since then, those types of technologies are coming into favor. They're no longer fringe, and this is becoming more of a mainstream kind of cancer therapy.
Yeah. And so when you say appear in imaging, are you still reading these images traditionally, or is there technology aiding with you or aiding you when you're interpreting the images?
Good question. Technology is there to help aid. Our system's in the process of buying software to help us read it. Right now I'm reading it as I would kind of traditionally, I think, as most people are reading their PET scans, which is the patients come in, they get injected with the radio tracer for imaging, they incubate for a bit. The images are taken, and then we're reading them. When we're looking from a theranostic standpoint, who's amenable for treatment, we want to see patients that have very high uptake of these tracers. Very high is a qualitative kind of subjective word, and even in literature, some say this is high because it's brighter than the liver. It's high because it's brighter than the salivary glands. It's higher because it's above some number that we've established as being a threshold from a relative kind of uptake standpoint. But ideally, I'd love to be able to go through and say this patient has 1,500 cc's of tumor, X% are expressing these particular markers to a certain extent that we know can allow us to get enough radiation therapy and to have a meaningful response. And that becomes the trickier part. So you have patients that we treat, we know at least you've got some lesions that are going to be amenable to treatment, some are not. It'd be nice to quantify it, it'd be nice to in the future. And I think we're on the way to get there, but the field is developing as we speak, which I think is one of the most exciting parts about it. But as new treatments come out, as these technologies are developed, we're not too far off where we can auto-isolate or auto-segment rather, the lesions on the imaging, kind of characterize them by what is or is not appropriate for being treated. We know that the amount of radiation that these tumors absorb is somewhat proportional to the kind of kill response we're going to see. Can we calculate if the tumor volume we even have with the uptake it's showing can even be destroyed by these therapies? And if it can, great. If not, we know before we even start that these are patients who need to be on a different type of drug. So these type of pre-treatment imaging kind of pathways are really important, and they're helping us select which patients should get treated, which patients shouldn't get treated. If there's a future where we have combo drugs or kind of cocktails, then we can say, great, the differentiated tumor gets treated with the standard Pluvicto, and these other lesions which won't be seen or don't have enough uptake, I can target the tumor microenvironment, more of a de-differentiated kind of tumor. And I think that's where we're going to see this going. It's not just to help us read the scans and kind of make us more efficient, but it's going to help quantify and really make this an objective evaluation of who should get what and when that should be.
Right. Well, and I'm glad you're talking about who, what, and when, because you pointed out that before your program existed, patients often had to travel or lacked access to the kind of imaging to therapy workflow that you now offer. What kind of gap did you see in your region that, you were like, oh, we have to do this here at Overlook?
So the biggest gap is going on the map and going to some of these the drug company websites and seeing, to kind of find a center app, and then you look and say, wait a minute, there's red dots all around where I am, but not where I am. When I speak to physicians here and say, well, where are your patients going? Where are they getting their care? And they're telling me, well, New York City might only be 20 miles from here, but that's a 2-hour drive if you're stuck in traffic, for some of these therapies, and same for trying to get down to Philly sometimes. So that kind of showed that the need exists. I know patients were leaving the system to get care, and as they should. We're not going to hold patients hostage until someone comes along to do this. But if we can get a program that doesn't just provide the services, I'm not excited by that. I want a program that provides the services and makes you want to stay here, not because you geographically kind of have to, but because I'm going to give you the same care you're going to get at a big academic center. I mean, that's what was the impetus for starting it here. Is not just a line item or a checkbox for the hospital to say that we can do this, or for a department to say, look, we're just a dispensary. It was to take ownership of what the technology was for the region and turn it into a referral hub, someplace where patients want to come as a destination. And I think that's what's made it as successful as it has been.
Yeah. And so when you decided to start this program, like how does one even go about doing that? Who do you need to talk to within your facility? What are you actually saying to them? I can only speak from a vendor's perspective, but I know that the approval process in healthcare is nightmarish at best.
The easy answer to that question is that you go to the vendor's websites and you fill out a little form that says I'm interested, and they send a rep and you talk to them, or you go to the state and say I want to start a program, and they say, great, here's the pile of paperwork you have to get involved with. But I think what matters most is the interest and the passion to want to have it, and that'll make you hungry for going through all the literature that was available at the time, like I did, to make sure that I knew what I was getting myself into. Going around and then literally door to door talking to the oncologists and urologists and radiation oncologists and saying, this is what I'd like to do. These are the outcomes that people are seeing if we select the patients appropriately. This is really exciting. What kind of patients do you have? This is the type of workup we need to do. I was really hands-on when I started. I was making the phone calls to patient consults myself. I was booking them myself. But being intimately involved with developing it from the ground up now makes me, I think, a bit more prepared, because I know what it's like to have to talk to the insurance companies, and I understand the revenue cycle, and that becomes important for a hospital system, because they're going to lay out money for these therapies up front. They're not going to get paid for a bit, and on some days when I've got 5 and 6 therapies, that's a huge amount of money that, I certainly didn't appreciate at the time why the CFO is getting, it's getting a bit nervous, because money's getting laid out. We're not 100% certain how the reimbursement is going to look early on, and they very appreciative that the system here was kind of patient with what that process was. And I think a lot of that had to do with me presenting what a vision could look like for it. That this is this is not just going to be a place where patients come, we inject, and they move on. We're going to provide a full service care. The oncologists, the urologists, or the referrers know that when they send the patients to us, we're going to do our job to do the imaging up front, do the due diligence for clearing the patients. We're not doing this just because we can. We have to get the right patients, the therapies. And when I go back, we should have our fellow do this last year. She went and looked at all of our patients, and we kind of found that while half our patients never would have met criteria for some of the early drug trials, they were kind of too sick. The ones who did had just as good outcomes with us as they did at these big academic centers, and I think that really kind of helped us. And so, look, we've got two patient populations in the community setting. We have the ones that are kind of teed up that fit the mold for these trials, and then we have others that are just quite sick, and we're using these therapies from a palliative standpoint. The patients, they're feeling better, so that there's he was anecdotally a reason to keep doing it. But we're having those discussions, and then talking to the referrers and saying, look, I know you expected this amount of life expectancy gain, you didn't get it, but these are the patients you're sending me. These are the ones that are in the trials that you're getting your data from. They're very discrepant, and I think going over some of those early outcomes with them certainly helped us grow as well, because we could temper what the expectation is supposed to be. But a lot of that was really just getting my hands on everything I could read, so that I could be the informed one, which the entire system didn't have anybody like this before. So a lot of this was myself learning, and then teaching anybody who would listen what this is and what's entailed. And I think that's what's been helping us so far.
Yeah. And so I want to push a little bit about the internal approval process, just because I know, like, every single facility, even if they're within a larger IDN, is going to have a different internal approval process. So it's not like you can just give us a roadmap for anybody who wants to make a phone call, get some Pluvicto and get a Theranostics program together. But like, how would you advise someone about navigating those internal approvals, right? Like, it's such a piece of the puzzle that I think is so often missing from healthcare, is how these facilities are actually working and what voices need to be involved.
Yeah, that's a good question. I don't know all the voices. I'd love to. Still,
Right. I mean, that's what I'm saying. No one knows.
through that process. The I guess from the physician side, getting the referrers, getting the CMO, getting even the CEO excited about what this could be for the hospital, I think was the biggest thing I could do. Being a cheerleader for that, I presented at trustee meetings, I presented grand rounds, I presented to anyone who I could on the clinical side of things, to say, this is something we don't have, this is something we need. And then once there was, I think, a lot of interest in wanting to pursue this, that's where we got the CFO involved. When I spoke to the drug companies themselves, I put them in contact with our finance team, our authorization teams, and these companies have representatives for each one of those. There's ones I speak to from a product side and a sales side, and there's representatives who come in and just talk to our billings team. So I wasn't in all those discussions, but all of those were happening simultaneously. The biggest for us, I think, from a hurdle standpoint, was really getting the radiation safety approvals. making sure that we had the drugs on the license. And, from a practical standpoint, it's not terribly difficult. We have a fantastic radiation safety officer who took ownership of that. From a state standpoint, I hope New Jersey, someone in New Jersey is listening. You guys are horrible. This was one of the longest and most arduous processes, and um, it didn't have to be. I think there's a ton that more we could be doing at this hospital that we kind of have to pump the brakes on a little bit, just because the approvals at the state level take so long. I went on paternity leave, and it took 7 months to get the other nuke med physician on the license, and that's not a hospital problem. That was a state one. I don't know if that's in every state, but New Jersey, you guys got to do better.
Yeah, I mean, I feel like that's got to be every state to some degree. But being from New Jersey, as I said, I also would like to suggest New Jersey to get your shit together. Excuse my language. So you were saying earlier, and this is something you talk about publicly, that every patient, every cancer is different, and so now that we are at this point where we can start to treat them that way, how does that start to change everything else going on internally with your program, workflow, staffing, mindset of the team, right?
So I guess I was quite fortunate that because I came, there was nothing, which means we could build it the exact way that we wanted to. And I tried to keep it as fluid as I could, knowing that we're going to find better ways to do things along the way. And then we had to have a way to have easily adopt those into our workflow. At this point, we've been able to bring on a nurse practitioner within the radiology department. We're able to bring on a scheduler on one of our MOAs, but also happens to be a CMA, and has clinical kind of workflow experience. And we have this giant spreadsheet that we're able to track the patients on. So we have someone who's reviewing every single one of the labs every 2 weeks, making sure that the trends are where they need to be. We're not seeing bone marrow suppression because of the radiation toxicity. There's a way for her to easily get in contact with me and essentially say, look, this patient is not doing as well, whether PSA is rising if they're on Pluvicto for prostate cancer. So there's we have people now who are monitoring the labs and making, and from a progress standpoint, we have someone at the front desk whose primary role is being the face of the program, talking to the patients, having a point person. I think people really appreciate having that consistency, which then frees me up to actually do the nuclear oncology part of all of this, which is reviewing the scans with a fine-tooth comb. How many lesions about are we seeing? What percentage of them are meeting certain thresholds? At least, for what we have right now in the literature that would suggest these are going to be lesions that are treated well with a certain drug. Is there a better one out there? If I think someone's a good candidate for a theranostic treatment, but we don't have the drug here, but there's one in trials. I'm sending them there. We're trying to do our best to make sure that whatever we're giving the patients, the best we can offer them. And the focus here a lot is on how do you integrate imaging into selecting the patients, keeping them in the program. We image everybody after they get therapy. That's not commonly done. About half the centers don't do that. But we've seen it. If enough of the lesions have been destroyed, then the next time I give you intravenous radiation therapy, it's not going to go anywhere. So can I put you on a bit of a holiday? We've got patients on a year break from getting radiation therapy. Their PSAs are stable. Their PET scans are stable. We can watch them. And then when they seem to progress again, we can restart them on therapy. And we're not just saying the manufacturer says, give this every 6 weeks and you're done. If we can prolong the amount of time somebody's not on these second and third line chemotherapy agents with these horrible side effects, then we're not just giving them the longevity benefit. We're giving them a bit more from a quality of life standpoint. And I think that for a lot of our patients, certainly the prostate cancer patients who are a bit older in the first place, they're really appreciative of that. So it's not just, do I greenlight you for therapy? It's while we're giving you treatment, when's the best time to give you this drug? How do I give you a chance to recover? How do I extend the amount of time where I don't need to start considering other types of medications because you're otherwise healthy enough to keep going?
Interesting. I want to make sure I have my mind wrapped around that, because that feels very cool. So So can you just say more on like how you're assessing this amount of time that you like? How do I even think about it? It's not downtime, but like time in between treatment.
Sure. Uh, so there's the kind of the minimum requirements that's it from a safety standpoint. We know that when we give intravenous radiation therapy, while these drugs are trying to localize the tumors, they're flowing through your bone marrow, they're flowing through kidneys, they're flowing through liver. All these organs are getting exposed to radiation therapy. If you've got a patient with a large volume of bone metastasis and we localize radiation to it, all the normal surrounding bone marrow is going to get exposed to some degree. Um, so I know for sure 2 weeks after we give this drug, there's going to be a drop in their white count, their hemoglobin, their platelets. That's an expected finding. So the time between therapies is on every 6 weeks for Pluvicto, every 8 weeks for Lutathera, in part is incorporating that aspect into it. I'm not going to shorten the time between doses, but um, after every therapy, we're bringing the patients back and we're doing imaging. These drugs kind of have two kinds of radiation they're emitting. The majority is this beta emitter for curing the cancer cells, but there's a gamma component that we can image on our SPECT equipment. So every patient gets scans, which means I can see exactly where the therapy went. If I can see where it went, then I can compare its distribution to prior scans. And if there comes a point where we're seeing along the way that the lesions are getting bigger, they're getting brighter, there's more of them, patient clinically is doing worse, we can tell pretty quick and say, you know what, this therapy is not working for you the way we thought it was. We have to find you a drug that's going to work, and we'll stop treatment. If we didn't do that imaging, I wouldn't necessarily know this. A lot of patients, they're on anti-hormonal medications for prostate cancer. The tumor markers we would typically want to use, like a PSA, they're not as high as they should be for the amount of tumor volume there is. And some of that is because the lesions are mutating and they're not kind of producing as much. So when things become unreliable, I've got to find some way to manage the patient. I can't not only give you, 120 gray per lesion, you got 50 lesions and then I have no idea where it went. I think that's irresponsible. So we're using these images to guide therapy, but the flip side is if we've got some patients, I give them 2 doses, and on the 3rd dose, when they come in for imaging, I don't see any more lesions anymore. When I say, great, the next time I give you a therapy, there's a good chance it's going to circulate in the blood, go through the bone marrow, the kidneys, the liver, get excreted, bind to nothing, and all I did was give you radiation toxicities potentially, and wasted one of your approved doses from your insurance company. So for those patients, we'll stop the therapy. We'll give them what we call a radiation holiday. We'll keep following them with labs. We'll do intermittent PET scans. But the first sign we see that there is a recurrence or a progression, we can restart therapy. But because unfortunately, at least for now, these therapies aren't cures. I'm buying you quality of lifetime. If this didn't exist, you'd be going on a 2nd or 3rd line chemotherapy, and they've got neuropathy and hair loss and vomiting, and these patients feel miserable. So if you're going to wind up possibly there anyway, but I can give you the amount of time you don't have to be on it as a maximum, and I can decrease total amounts of cycles you might have to be on total, you're going to feel better. You're going to go back to your life. You're going to get a lot of your life back. And I think that's been, from our standpoint, that's the reason to do any of this, is get these patients pain-free, get them to their next birthday, the next Christmas, the wedding, whatever it is, that I'm going on vacation, not feeling sick and miserable. And I've got a lot of patients coming back saying, look, you gave me my husband his life back, and that could just mean he's able to go back to working on his farm a bit more. I love hearing patients tell me, I overdid it over the weekend. I started building houses again. I haven't done that as a volunteer for 2 years because I felt so good. But I think we can maximize that by doing these kind of intermittent doses.
I believe you were using a diagnostic probe from prostate cancer and applying it to high-grade brain tumors. Where did that idea come from? What made you think it could work? And what have you learned so far about not just these, using these techniques for other cancers, but overall future of various cancer treatments?
So when I mean, a nuclear medicine kind of community started using these tumor-specific PET tracers on patients, you kind of start seeing that things other than what they may have been initially designed to test for start popping up. So someone has a brain lesion, they have a meningioma that's going to pop up on the PSMA PETs and the dotatate PETs, like we use for neuroendocrine tumor. Other cancers, breast cancer sometimes pops up on the neuroendocrine tumor PET scan. So we're seeing other things that kind of pop up, and then what we're learning is that because of that, there's opportunities if there isn't a drug available to possibly image or even treat those kinds of lesions. The high-grade glioma is like glioblastoma multiforme. That's a very aggressive brain tumor. Was showing up on these PSMA PET scans. And then when we kind of look into it a bit more, and you're doing the pathology on it, you're realizing that these PSMA PET tracers are binding to the tumor-specific endothelial cells of these high-grade brain tumors. So they're binding to the vasculature, which is very cool because it means you don't have to now get these tracers to cross the blood-brain barrier to do something. They're localizing to the tumor itself. So what we have in the neuro-oncology space is that on MRI, some of these lesions can look very similar once they've had all this radiation therapy and treatment to either a worsening disease picture or post-treatment changes, radiation necrosis. And when you do the MRI, they become equivocal. You do them again in 3 months, and 3 months, and 3 months, and you follow them. And then some of these will get better. You say, great, that was radiation necrosis. Some of them get worse, and you go, well, this was real viable tumor that we maybe could have picked up months before. And for some of these patients, that's a big deal because you could start them on new medication, and their life expectancy might have been 6 months at that time point. So kind of what my proposal was to the hospital here is that can we use this PSMA PET tracer, which in a couple of case reports had been used previously, but how do you make this kind of a mainstream clinical tool for us? And we did a couple of patients, had some pathology proven, kind of positive for recurrence, and we've been able to build this now into our kind of regular care here within the center. So for neurosurgical patients, from a brain tumor standpoint, if there's MRI findings that are equivocal for disease recurrence, worsening disease versus a radiation necrosis, we have these PET tracers available. We have grants to kind of support the funding for it. It's off-label, and we'll image the patients with a PET scan. We'll then fuse it on one of our computers to the MRI, and we're giving kind of the surgeons a new roadmap for how to, which part of these lesions are viable and which aren't. I've got pictures where, before they were referred here, there was a biopsy done, and you can see where the needle was placed in the brain tumor. We do the PET scan, and you got like a horseshoe picture of a viable tumor, and the needle's right in the middle where there's nothing. And you think, well, had we had these types of pictures beforehand, you would have known exactly where to target to prove that this was viable, and that's now been kind of a part of our program. And we're using that for brain tumors. The neuroendocrine tracers we've been using for meningiomas. We've been using them for especially basal skull meningiomas, which are very difficult to operate on, with the idea being is similarly, if I can show that we're getting enough of the tracer to these sites, then we can treat them. And there are trials now using the Lutathera to treat basal skull meningiomas. We used one last year to treat a very aggressive basal skull paraganglioma that had eroded through the bone, was pushing on the patient's brainstem, not operable candidate, not responding to anything. Kind of came to us as a latch stitch kind of effort to help him. And we did what we typically do. We brought him in, did the imaging, calculated what kind of dose we thought would go to these lesions, shrunk the tumor enough, headaches went away, swallowing got better. Patient was kind of in a better position because of this. But when you think about where the future of this is going, is it's nice to have the new tracers for new cancers, one specifically for ER-positive breast cancer, one specifically for triple-negative breast cancer, sarcomas, or colon cancer. And they're all going to have, at some point, their own specific PET tracer, which then we're going to label with the radioactivity for therapy and have kind of a Theranostics pair. But it's nice if there's some crosstalk between them, so that while we're waiting, we have something to offer patients.
Yeah, for sure. I want to ask you, at the beginning of that response, you were touching on something to do with the vasculature, right? And how it ties in. Did you, I believe, I could be wrong, correct me if I'm wrong, but wasn't a lot of your early training and research specifically on vascular physiology?
Yeah, that's what the PhD's in. It's all vascular
Right.
physiology. Yeah.
So
Um,
it is that how did that come into play when figuring all this out to some degree? Like, did you kind of have a bunch of this in your back pocket already?
yes, I had the mechanisms in the back pocket for sure. And when I was doing kind of early experiments, a lot of it was focused on we were looking at inflammatory imaging in diabetes, and can we label vasculature or vascular components with these kind of probes, and that's always kind of stuck with me, certainly for the brain tumors, because a lot of the difficulty we have in getting drugs to them is that you've got to have to cross this blood-brain barrier. But if you can identify vascular targets and park your radiation there, some of these radioactive molecules will travel 2 and 3 millimeters across a 200 micron blood-brain barrier. I don't have to cross it. I just got to get it close and dump the radiation on the other side of it. And it certainly helps seeing kind of in real time when I was doing the research what the binding rates were for some of these probes. And at that time we were looking at how do we deliver MS type drugs to there, but it doesn't really matter whether the payload is for MS or it's a radiation for tumors. The idea is the same. Can you use the vasculature as your conduit and even as your target for therapies, and instead of going to the tumor, certainly for things like GBM or these other very aggressive tumors, if they're poorly differentiated and they've kind of a lot of limitations, you might not have a specific target on the surface to go after. But you have the blood vessels feeding them, and those blood vessels are typically a bit different than the normal ones in the body. And now we have these integrin kind of binding Theranostics pairs, which are doing just that. Can you target the tumor-specific microvasculature to put your radiation therapy or your antivascular medications to kill the tumors?
So looking at the next 5-10 years ahead, what radio tracers, therapies, cancers do you believe are gonna be defining the next chapter of Theranostics?
Sure. So I think there's two things we have to focus on. One is the type of radiation that we're going to be using to pair for these nuclear theranostic agents, and the other is the tracers themselves. So from a radiation therapy standpoint, a lot of what we're using now are lutetium 177 and yttrium-90 kind of isotopes. Those produce beta emissions. It's predictable, at least for now. But one of the issues we're having with these types of treatments in general is that they're a lot of reliant on kind of high oxygen content in these tumor microenvironments. We're going to make free radicals. We're going to make superoxide with the radiation attacking those specific elements, and that's what's going to be then used to destroy the cells. We're looking at a lot of single-strand DNA breaks with beta emitters, which is nice, but I need double-stranded breaks to kill cancer cells. So I think as this moves forward, and we're going to see things like the actiniums, these alpha emitters, so bigger, heavier molecules that will deliver much more energy over a shorter period. So what you're going to wind up having is a much higher kill rate for the same amount of radiation that's produced. And we're seeing these now in trials where someone with a lutetium 177 PSMA, that's Pluvicto, therapy, did well, had a recurrence in a couple months. Afterwards was put on the actinium therapy, which is an alpha emitter. Essentially you have a radiologic remission, which is incredible. One of the challenges is generating enough of these therapies in a cost-effective manner. But you've got companies kind of all over the world really looking at and trying to tackle this, because I think that's going to be an incredible gain for us. And then the other is the tracers themselves. So right now, the tumoring therapies are Pluvicto and Lutathera. They're targeting very specific, well-differentiated tumor markers. But you have the triple-negative breast cancers, you have pancreatic cancer and ovarian, colon that don't have a marker as of yet. Many of them, they might not have a specific tumor marker if they wind up being exceptionally aggressive. So you have things like FAPI, which are targeting tumor microenvironment fibroblasts, cell populations that are kind of a high density in those environments. And from a radiation standpoint, that's great. If I can get it close enough to the tumor we can kill the tumor with the radiation therapy. So, those new targets, I think, are what's going to make this, even bigger than what it is, to the point where I think you're going to wind up having nuclear oncology as a burgeoning specialty within nuclear medicine, where you have kind of experts in the imaging and treatment of cancers with these therapies, alongside your radiation oncologists, your medical oncologists, surgical oncologists. Just because there's so many cancers that are going to be touched by this. I think there's a report out of Europe that said, and I forget the years in the future, but something like 65% of all cancers are going to have a Theranostics pair that can be used in treating them.
Okay, so for health systems or radiology groups, like, if somebody wants a piece of this pie, if someone wants to, build their own program, they don't know where to start, in terms of like a few small actionable steps, what, wake up tomorrow morning, what should they do?
I would go to the Nuclear Medicine Society's website. I was actually there this morning in preparation for this question. They've got incredible resources. What's required, what kind of teams are required, what does the landscape look like, and that'll get you an idea of the type of personnel you should have available to deliver the type of care that you want. I would talk to the vendors that are manufacturing these therapies, and they have a vested interest in your success too. That's how they're going to get the pipeline in. And they've got teams in place to help you get your billing set up, get ordering set up. You're going to have to talk to your radiation safety officers and you'll get these drugs on the state on your license. That's kind of the bare minimum that you have to do just to get these things approved and through. And I think if you can get all that, then while you're waiting for your state to approve this over the next 6 months, that's when you got to start talking to your referrers and building a relationship with them, talking to your radiation oncologists that are there. They might be interested in helping from a dosimetry standpoint. They might even be the ones doing this. They've got so much, kind of background in nuclear radiology anyway, or nuclear physiology anyway. A lot of centers are turning to them, but I think that's where I would start first, and then the other is go to the Theranostics conferences, and you're going to meet people like myself, other kind of thought leaders, and you're going to gain kind of the clinical insight that you're not going to see in reading the manuscripts. How do you go into handle the patient when all of a sudden they've they're not feeling where they want to go to the emergency room a day after you just gave them very high doses of radiation therapy, and you don't want to contaminate the entire department, and those kind of practical but necessary kind of scenarios and questions are going to come up.
Awesome. Well, I think that is all the time that we have today. James, do you have anything you want to plug or anything that you want to like drive people to, in addition to the resources that you just gave us?
I think that because Theranostics is so rapidly evolving, and you've got so many either new centers popping up or centers in the area that are kind of doing their best to provide kind of this necessary service. I think from a patient standpoint, it's kind of nice to know that there are differences in how these are delivered. From our standpoint here, where we're doing our best to do a lot of monitoring with blood work, do monitoring with imaging. We're really trying to make give our community here kind of academic level care. I think there's a lot of, and I know this was just published too, there's a lot of variability in how care is delivered. So I think from the patient standpoint, when you're undergoing these therapies and you're talking to your providers, ask them, how are you going to monitor the progress? You're going to do imaging more than just blood work. Do you have the ability to do intermittent dosing? And it's not that they're necessarily difficult. It's just another thing that your provider's going to have to learn and pull in. But I think that's what's going to get you the best outcomes. And I think that's important. I don't really have a plug or anything like that.
No, it's absolutely no trouble. It's now just it's 2025. Sometimes people have like I don't know, a radiology Instagram or but whatever. Doesn't matter.
I should get one after this. Maybe I'll get more than 2 followers.
Yeah, absolutely. Well, anyway, James, thank you so much for joining us today on Rethink Imaging. Dr. James Cassuto is the Director of Nuclear Medicine at Overlook Medical Center and Assistant Associate Medical Director of Nuclear Medicine for Atlantic Medical Group. James, thank you so much for joining us today. I hope to have you back sometime.
I appreciate it. Thank you. Likewise.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.